أحب بس أشكر الدكتور هيثم على الدعوة الكريمة وأشكر مستشفى الشرطة على الدعوة الكريمة دي. بسم الله الرحمن الرحيم. Anesthesia for gastrointestinal endoscopy in the era of Covid-19. The Covid-19 pandemic has placed extraordinary demands on healthcare services worldwide. Strategic planning for acute Covid-19 care during the peak phase was the pandemic overshadowed the provision of diagnostic services, which have been further restricted by the need to minimize viral transmission to reduce risks to patients and staff. Providing sedation or anesthesia to patients undergoing gastrointestinal endoscopy is challenging in normal times. However, arrival of COVID-19 has increased the complexity on many fronts. There was a need to make rapid changes in our approach without compromising the safety and comfort of patients and healthcare workers. For example, data from the National Endoscopy Database indicates that total endoscopic activity fell rapidly to 5% of normal levels during the peak phase of the COVID-19 in the United Kingdom. In the deceleration phase of the pandemic, healthcare service rightly looked to implement measures to safely restart activity. Endoscopy capacity was restored as far as possible, while ensuring mechanisms are in place to reassure and protect patients and staff from avoidable risks. Our goals were avoidance of close proximity, minimizing the need for airway intervention, avoidance of potential aerosolization, safe but quick discharge. Pre-procedure evaluation and consenting. Evaluation of patients undergoing endoscopic procedures requires specific focus on airway assessment and exploration of aspiration risk. The providers can take advantage of telemedicine video consultation. Webcam-enabled computers are widely used, and smartphones allow similar experience. Many health systems in the USA and UK has such facilities that allow patients to consult their doctors from the comforts of their own location. It is important to involve the information technology department to create secure link on the hospital online portals of individual patients. Another advantage of tele-procedure evaluation is the ability to deploy anesthesia providers who have symptoms suggestive of COVID-19. Immediate pre-procedure examination. It was highly recommended that every patient presenting for endoscopic procedures should undergo tests that detect the virus itself using a polymerase chain reaction, PCR. Testing twice at 72 hours and 24 hours pre-procedure can reduce false negatives. Yet, the testing can't eliminate false negatives completely. As a result, auscultation and any other physical examination should be avoided unless deemed essential. Creative use of certain tools might allow to hear auscultatory sounds without being too physically close by. We can use digital cordless stethoscopes, cordless pulse oximeter probes, single-use thermometers. Airway evaluation, if deemed essential, should be performed from a safe distance of at least 6 feet and should be brief. Unsedated gastrointestinal endoscopy, both upper gastroendoscopy and colonoscopy may be performed with either no sedation or with topical anesthesia. and mild sedation. It is a common practice in many developing and some developed countries. Many patients might prefer to have minimum staff interaction. Unsedated endoscopy potentially facilitates such patients' preference. Upper gastrointestinal endoscopy without sedation can cause gagging, a common reason for failure. Use of topical anesthesia can suppress the pharyngeal reflex. Colonoscopy was in fact started as an unsedated procedure. Colonoscopy without sedation was found to be fairly safe. Sedation techniques. It is important to avoid aerosolization. To achieve this, limiting the use of mask ventilation, appropriate use of endotracheal intubation, avoidance of high flow nasal cannula, all types of unnecessary airway intervention should be avoided. Sedation techniques with minimal respiratory depression. Propofol-based sedation techniques are most popular in gastrointestinal endoscopy. These techniques needed modification to decrease the risk of exposure of healthcare workers to COVID-19. Oxygen administration may be accomplished either with nasal cannula or non-repressing mask. A face mask or face shield should be applied over the face to limit aerosolization. Regarding the choice of drugs, smaller doses of short-acting opioids, ketamine, and dexmed in combination with propofol are useful. General anesthesia with endotracheal intubation. Although traditional general anesthesia with endotracheal intubation might be acceptable in COVID-19 negative patients, existence of false negative and asymptomatic untested patients should be taken into account when planning for general anesthesia. Coronavirus causing COVID-19 can stay in air for significant period of time, and anesthesia providers, technicians, nurses, gastroenterologists are exposed for extended period of time for coronavirus causing COVID-19. A direct relationship between the risk of getting infection and the duration of exposure is established. Relation is also established between the dose of virus exposure and severity of infection. As a result, it is imperative to minimize both degree and duration of aerosolization. On a practical note, in the absence of any specific contraindication, rapid sequence induction and intubation approach should be used. Endotracheal intubation should be the most competent anesthesia provider in the room, followed by quick connection to heat moisture exchanger with high efficiency viral filter. Some filters are capable of preventing any coronavirus crossing over the breathing system site. This is the bacterial and viral filter, and it is very important to use this filter in our anesthesia machine. It is advisable to use video laryngoscope for all intubations. It is mandatory to have a functioning scavenging system. Extubation should be smooth with minimal coughing. A non-breathing face mask should be applied immediately after extubation to provide supplemental oxygen. This is the video-assisted laryngoscope, which minimizes exposure of the anesthetist to the airway of the patient. In the past, we have discouraged use of general endotracheal anesthesia and preferred deep sedation for patients undergoing endoscopy. However, in patients with any degree of suspicion of COVID-19, it is preferable to use general endotracheal anesthesia. What about personal protection of anesthesia providers? Protection of healthcare workers is essential, although practices are varied between individual hospitals depending on the availability of resources. We understand that this protection will change as a new evidence accumulates. Masks and face shields were used at all times for all patients. Care in the operating room, critical care units, and wards, regardless of COVID status, is very important. This was the BBI, which used for any endoscopic procedure for patients suspicious of COVID-19. Furthermore, N95 and powered air purifying respirators are used for all COVID positive patients or persons under investigation. N95 or PAPR are used for all intubations and extubation for anyone within 6 feet of the airway. The risks of the personnel in the procedure room is also from the fecal matter aerosolization. The duration of viral shedding in the feces is unknown, so we should take care. Thank you.